Thank you, Adam, for that wonderful and generous introduction. I hope it didn't age me too much. But I wanted to show you what collaborations look like when you start something with a low middle income country. So my topic for today is Brown and the University of the Philippines collaborations. This is an early picture, 1991 in May. I don't know if you can identify who is me many, many years ago when I was so much younger. There's Dr. Steve Opal, ID. There's the chair of the departments, and there are some postdocs and medical students. And one of the postdocs stayed 6 months to help build up the STI laboratory in the Philippines. And several nurses who were part of our Fogarty programs who came to train here at Brown. So, but this started long before 1991. I just couldn't find an older picture. And it all started with Dr. Charles Carpenter, who came from Case Western and became the chairman of the Department of Medicine here, and was the original director of our Center for AIDS Research, which I inherited. And Dr. Ernesto Domingo, who was the chair of medicine at the University of the Philippines, Manila. They were both at Case Western, and Dr. Domingo became eventually the chancellor of the University of Manila, Philippines. So he became a very powerful supporter of the Brown University of the Philippines collaboration. So it started with the AIDS International Training Research Program, which we called the A-TRIP. This was funded by the NIH in 1993 to provide HIV/AIDS training in Cambodia, Indonesia, Philippines, India, Ghana, and Kenya. And that occupied me and my children. They become road warriors because I would bring them to all these countries every time I went to work there. However, in 2010, the NIH asked us to drop the Philippines, considering it as a very low-risk HIV country. We tested 3,000 pregnant women, found 0 HIV. We tested 1,500 prisoners, 2% STI but 0 HIV. We tested, seafarers or migrants were coming in, and it was less than 1%. So the NIH said there's no reason to do HIV training and research in the Philippines, so you can drop it from your A-TRIP program. However, in 2014 and earlier, there was an over 800% increase in HIV in the Philippines, mostly in men who have sex with men and transgender persons. So we resumed HIV training in the Philippines. The A-TRIP ended in 2014 and was replaced by D43 mechanism through the Fogarty International Institute. The change was one university in the U.S. can only partner with one low-middle income country at one time. So instead of having India, Ghana, Kenya, Cambodia, Indonesia, we shifted to a D43 for Brown and the University of the Philippines and Brown and Kenya. So those were the D43's mechanism. So during the A-TRIP program, 21 Filipinos from multiple disciplines came for short-term training that is 3 to 6 months. They were doctors, nurses, public health, social scientists, basic scientists, and virologists. Nimia Simbulan was one of the trainees. She's Vice Chancellor now of UP Manila. Jamie Montoya, who came here for HIV and TB training, is now the President of the Philippines National Academy of Sciences and Technology. Reynaldo Imperial, who is a sociologist, became the Dean of the School of Public Health. Jodher Lim, is now the Director of Infection Control at the UP Philippine General Hospital and Director of SAGIP. SAGIP is to save, the HIV clinic in the Philippine General Hospital. The University of the Philippines, Philippine General Hospital is now 1,800 beds, but has been approved to expand to 2,200 beds in May 2025. If you look at the Miriam Hospital, it's around 300 beds. Rhode Island Hospital is about 800 beds. So this is talking about double the size of the hospitals that we have here. We have selected publications. I'm not going through all of them. These are just selected. We have had over 50 publications with our collaborations with the University of the Philippines. And Dr. Edsel Salvana has been part of this. And he came to Brown during the BIARI, which is a 2-week training for HIV at Brown, funded by Santander and Brown. And they spent 2 whole weeks here at Brown just talking about HIV, and 45 international investigators from all different countries of the world would come to Brown in the summer. So now we change it to the D43 University of the Philippines and Brown University training program for the prevention of HIV in vulnerable populations. And this was led by Donna Perarier from the School of Public Health, who unfortunately is now the Dean of the School of Public Health at Emory University. And I stayed here. Nimia, who was trained here at Brown, and is now the Vice Chancellor, and Lawfred Hernandez, who got his PhD. This is in response to the urgent need to develop the research and the curricular capacity for one of the fastest growing HIV epidemic in the world that occurred. And we also have the Brown UP Manila FIRST program, which is a part of the faculty of Brown, as well as students here at Brown who are interested in working on HIV research in the Philippines. And the outcomes of the D43, we had 3 faculty from the University of Manila who received their master's degree here at Brown University School of Public Health, statistics, epidemiology, and global and public health. 2 PhD level trainees, 1 in epidemiology and 1 in behavioral health and social scientists. 5 additional UP Manila Fogarty Fellows who received medium training and long distance mentorship. The trainees for the first authored participated in over 20 publications focused on HIV care and prevention in the Philippines for the D43. That's aside from the other publications from the A trip. The Brown UP Manila program provided short-term training through the form of in-country seminars, workshops, scientific writing, grant writing, and professional networking. And Don and I, for 5 years, went to the Philippines to do 3-day symposiums every single year, working with academicians, working with physicians, doctors, public health specialists, and non-governmental organizations that were leading the care for MSM and transgender women. So, unfortunately, the D43 programs are no longer being funded. Trump administration, many global health funds have been stopped, but I would like to congratulate Adam and his group. They got the last D43 for HIV training program with Ukraine. And we will continue our collaborations with the Philippines, NGOs, and other institutions through other grant mechanisms. And that's why I thought Edsel should be here, because he is going to continue our over 3 decades of collaborations with the University of the Philippines, Manila. Thank you so much.
So good evening, everyone. It's a pleasure to be here. Thank you for inviting me, and it's a pleasure to come back to Brown and speak about what's going on in the Philippines. Let me see if I can. All right, so this is HIV crisis in the Philippines, a story of advocacy, molecular, detective work, and resilience. I'm actually surprised they were telling me there's so many people, and I'm Susan. In the Philippines, we call everybody ma'am or sir. Yeah. So I say, I was saying maybe it's because they serve the Filipino food, right? And so that's a cue, Megan. Maybe you should order Filipino every time, so you pack the hall. But it's very good food. I hope you guys liked it. So I'm going to tell a little bit of it's not your usual scientific talk. There are parts that are science, but I think every single HIV doctor knows that you can't work in the HIV field without becoming an advocate. Because when you work with patients, especially in the early days of HIV, it's, you advocate for them. Because at that time, it was very bleak, and now we've gotten to a point where, it's become a chronic disease. But you cannot work in this space without having so much empathy, especially in the Philippines, where there's still a tremendous amount of stigma. So just my disclosures doesn't really conflict with what I'm going to talk about. So these were the objectives that I gave. We want to, Ma'am Susan already gave a hint of what happened. And we also looked at molecular subtypes, which weren't all that popular, although the first time I heard about it was from Rami when I was here visiting. And after the COVID pandemic, with the variants, actually, people started paying more attention to that. And also the advocacy that shaped the response. So back in 2013, this came out. I think this was in JAMA, and there was everybody was saying, like Ma'am Susan said, that the NIH pulled out because there was just no HIV in the Philippines. When I did medical school from 1996 to 2001, I was at the Philippine General Hospital. I saw 2 cases of HIV. That's it. 5 years, and nobody wanted to touch them. There was so much stigma involved. And so we were thinking, maybe people aren't getting tested, but eventually they're going to end up in the hospital, right? And we weren't seeing that. We were only seeing that over 5 years. And there was a lot of talk about it. What's going on in the Philippines? Are people not having sex? That's not true. Our STI rates are similar to everyone else in the region, and we have the highest fertility rate back home as well. And so for a while, people were just saying, yeah, I don't know, maybe dengue. Everybody has dengue. Is it a genetic factor? I was talking to one of the students earlier who had Filipino ancestry, and as you know, there's no such thing as a genetic Filipino. We're a mix of everything. Like, we're the mongrels of the world. So it's, that couldn't have been it. And so started to unravel that. So I don't know if some of you know who Michael Letterman is. He was at Case when I was at Case as a fellow. That's me so many years ago. And he said, why don't you study HIV with me? And at that time, I did not know that Michael never asked clinical fellows, because I have clinical fellows to join his lab. So I don't know what he saw in me, but at that time, so I turned him down flat. If you know Michael, Michael's like a very prominent HIV researcher. I said, I want to study worms. There's no HIV back home. And so this guy comes in, his name is Jim Kazura. He's a hematologist, but he studies worms in the blood, so lymphatic filariasis. He said, why don't you come work with me? And I did. That's what I did. And I was all set to go home in the Philippines. I was certified in tropical medicine as well. I got a diploma in tropical medicine. And, nobody's really concerned. This is the map. Philippines is over here. And you can see it's almost white. Almost no HIV there. In contrast, sub-Saharan Africa at that time had about 20 million cases of HIV. 1 million in the United States, 1 million in Brazil. 1 million in Thailand, actually. Yeah, but the Philippines, nope. So, this is, when I came home, science heard about it. And the best way to put pressure on someone is to put them in science and write under their trailblazer, ? And I said, this isn't right. But I did come home. I was going to do Trop Med. But yeah, so that science reporter kind of put me on the spot. This is what HIV was. So I came home 2008 is when I started practice at the Philippine General Hospital. And remember what I told you. If HIV, even if people are not testing, these people will eventually end up in the hospital. And that's what I started seeing. I saw only 2 cases in my whole medical school. When I came home in 2008, I started seeing young men dying of cryptococcus meningitis, pneumocystis pneumonia, disseminated tuberculosis, CMV, you name it. And I was trying to say, something is going on. Sounds like our luck has run out. Because I think at that time, since we couldn't identify anything about what was going on in the Philippines, maybe we were just lucky. And now, that's kind of the end of the line, and we're actually going to see an epidemic. So I shifted my research also from Trop Med to HIV. So you can see that the doubling time started to go up. And it's really curious because look at that. There's like very, very few. There were 2 cases in 1984, only, under 1,000 cases for the longest time. And this was the increase. And I'll show you later what it looks like. But here's one thing. At that time, half of the infections were local and half of the infections were imported. OFWs here means overseas foreign workers, meaning people who go abroad and then come home and get HIV infected. And so that's the blue line. But this red line is local transmissions. And so our local epidemic really did start to take off at that point. And this was actually an MSM epidemic at that time. So, and there's like a 5-fold increase in the prevalence among MSM. And this is around 2009. And most of it is sexual contact, like 89% of sexual contact, very little IV drug use going on. There was maternal to child as well. And again, this is 2009. So the situation was there were very few healthcare workers trained formally in HIV. When we were starting to see all these cases in the hospital, there were actually just 2 of us who had formal training in HIV. And that was concerning. And the problem was the stigma was so tremendous that even the doctors didn't want to test anyone. And even people in the lab, I had a colleague who got a needle stick, and she went to the lab to get tested. And the med tech told her, that's because you're thinking about pleasure before, it was a needle stick. And she was being judged. That's how bad it was. And of course, the social stigma was tremendous. The condom use was 30%, if that, not even consistently and correctly. And so we had the elements of, we were starting to see more and more cases, and we were really not prepared for anything like this. And there were just a few treatment hubs. At the Philippine General Hospital, we only had clinic on Wednesdays. It's like one of the major hospitals in the Philippines, and we really didn't have that much capacity. And we only had 5 ARV agents at that point. We had nevirapine, efavirenz, tenofovir, TDF, 3TC, lamivudine, and abacavir. Oh, and we had stavudine. Nobody wants to use that anymore. So the story of my advocacy for HIV started actually with Australian medical students. They were rotating through the Philippine General Hospital, and they felt so sorry for our clinic. We didn't even have a CD4 counter or a viral load machine. And so they said, we're going to put together a concert in Australia, and the proceeds will go to you so you can get a CD4 machine. And they told me, all you have to do to get all that money, to get that machine, is to do your own little rock concert. I said, how hard could that be, right? So this is where I get into from medicine to organize a rock concert. So I became a rock concert producer. It turned into a monster. It's like we had the concert in the third largest mall in the world, which they gave the venue for free as well. We had acts that were regionally known. So there was a very positive feedback in terms of trying to raise awareness, because I think people were starting to feel that, it's like the calm before the storm, and that everybody should kind of pitch in. We even had an MTV commercial. So I was really happy, not because of me, actually, because of the residents, because of the fellows. They really threw themselves into this, and they're now leaders in their own right. But yes, we had a rock concert, and we ended up in science again. So you can see our posters over there. But here's the thing. It says, although some governments are waking up to the problem, Khan says, others are in denial. The Philippines is coming around thanks to me and my colleagues, who kicked off a new HIV awareness campaign with a September 5 benefit concert. They are following up with school visits and plans to pressure the government to make HIV/AIDS intervention a priority. This is our window of opportunity, says me, if it hasn't passed yet. I said no such thing. You know how, that joke where somebody's drowning and everyone's just looking, and then finally somebody jumps in and saves that person and then comes back, and then the reporters go, oh, you're such a hero, you're very brave. What made you save that guy? And so the guy says, before I answer that question, I have a question. Who the heck pushed me? So it's kind of like that, except it's science. But, you got to own it, right? So I started talking to media. Beth Morrissey was actually, she was a Fulbright fellow in the Philippines with the biggest network at that time, and she heard about the HIV, and she made it her report. And so we started talking. This guy is Jay Ruiz. He's like a presidential spokesperson right now. But the bottom line is he picked up on this, and he made a lot of series of reports. We were the headline news that day. So everybody started talking about it. But Jay also said, how people have such short attention spans, everybody's going to talk about. This was before social media was all over the place. This was like the evening news. He said, there's no way we can sustain this unless we keep reporting. And so we did like 5 headline news reports every single day. And that was really what drove awareness. So on the third day, I was going like, what the heck are we going to do to push more awareness? We were running out of stories. We were talking about the rise among call center workers, BPO, business product outsourcing. We were talking about healthcare worker risk. Then on the third day, I said, Jay, let's test you. And we tested him on air. Boy, did he really sweat it out while he was waiting for it was negative. But the bottom line was, when we saw that, actually the next day, there were like lines of people in our clinic waiting to get tested. So media really works when you push. And remember, this is a country that has tremendous stigma for HIV. But if you see it on the news, it must be something mainstream that people can appreciate. Like with the Katie Couric effect. I don't know if you guys remember that. When she got a colonoscopy, lots of other people got a colonoscopy. So that's another thing. We wrote, we talked about this in the International AIDS Conference as well. And we also did, specials on healthcare workers risk, because I had a resident who was pulling out a nasogastric tube on a patient who was not on meds, and it splashed her eyes. And, it just made everybody aware that, you gotta take care, be careful, post-exposure prophylaxis as well. I was invited to do editorials in the national journals, and so I wrote, we gotta do something about this. And we actually got the Department of Health to declare it an AIDS epidemic at that point, which nobody was really paying that much attention to. It even got to Dubai, all the way to the Dubai newspaper. So we made a lot of noise. We got people to pay attention. And we also recruited all the doctors. This was actually with the Philippine College of Physicians that we organized. And guess who came? Michael Lederman. The guy I turned down flat. I called him and I said, Michael, there's actually HIV in the Philippines. Help. And he was very gracious. He came. He helped us set up as well. And of course, Dr. Susan was also around, and we were starting to talk about these collaborations. Again, the NIH pulled their funding out at the worst possible time, because that was 2010, and we only started to recognize it 2009 is when we did the rock concert. And it's interesting because I'm a nerd, so I always want measurable outcomes. So when we were looking at all those TV appearances and even the Red Party, you can see that the number of people getting tested daily goes up, especially when we aired that thing where Jay got himself tested. The problem is, if you stop, it goes back down. And TV works the best, actually. We did some radio, it didn't really bump it up. But this really had a powerful effect on me. That basically told me, I can see patients, I know the science, I know ARVs and everything. But if people don't get tested, you can't get them into clinic, you can't save their lives. And so, as a doctor, as an advocate, you got to engage with media. Unfortunately, you got to be active now on social media as well. But it's really, really important that you make that commitment to get the message out. And so as scientists, we like, keeping to ourselves. That's not acceptable when you're working with a disease, a communicable disease that, people, if you get diagnosed early, you do so much better and you don't transmit to other people, which we didn't really know that as much at that time. We got our CD4 machine after all that. So, and this was a paper I wrote 2012, and this was before U equals U. But we already had a feeling that, test and treat was really the way to go. And the Secretary of Health at that time did agree with this concept, except that, the hardest part is really getting people tested. And I thought that, we really have to push the advocacy some more to save more lives. Also, at that point, if somebody had HIV, if you were a med student, you know what people did to you? They told you, get out of medicine, you're not welcome here. And so I said, that's not acceptable, And so we were able to kind of change the culture around that, especially when U equals U came along, then it was a lot better as well. So going back to that 2009 curve that I was showing, so nowadays it's actually 55 new cases. And this is what it looks like. It's predominantly male and really young. 15 to 34 years old is 80% of new cases. And so it's a young epidemic, mostly MSM. And this is the total, which is still a very small number, 153,000 in a country of 110 million people, but it's one of the fastest growing. So let's put that in context. In contrast, we had one new case every day in 2008. So 55-fold increase in the last 15 years. These were the number confirmed, plateau during the pandemic because obviously we weren't testing. But, so we did well. We got people on treatment. People were doing well. Then the pandemic hit. We lost a lot of patients. We were mailing meds, but some people just completely fell off. And then when we started opening up again, it really felt like 2009 again. We had people in the hospital with pneumocystis pneumonia, crypto meningitis, and so we said, we gotta push. This is what the curve looks like. At this point, it was starting to plateau, and then it went down during the pandemic. This is 2020, but once we opened up, it went back faster. We're starting to see a plateau here, so I'm hoping maybe, but it's anybody's guess. So new cases in the world from 2010 to 2024 were down by 32%. In the Philippines, it's more than 1,000%. So it's not a stock market, it's HIV. So it's a real problem. and we have one of the highest infection rates in the Asia Pacific. And so you can see there are not very many of these pink areas. Those are where cases of HIV have increased by 70% or more. So we're really in the minority, whereas it's stable in sub-Saharan Africa and in many other parts of the world, in Thailand. So the question that I asked myself was, aside from all that advocacy work, as a scientist, I need to contribute to figuring out what happened. And so, there was a really high circumcision rate in the Philippines, even though it's a predominantly Catholic country. Before that, we were actually predominantly Muslim. So the circumcision practices kind of carried over. And so if it's a heterosexual epidemic, there's actually a protective effect of circumcision on HIV transmission. But if it's MSM, that protection goes away. Increased local transmission, most definitely. Increased MSM transmission. And this is where the molecular epidemiology data came. When I was here, Dr. Cantor gave a talk about molecular subtypes, and I had kind of an aha moment. No one's really looked at that back home, and so maybe it's something that I want to look at. When I looked at, there were like 100 sequences of HIV sequenced up to around 2010. And so there wasn't anything, and most of these were old samples as well. And so we actually looked at it, and we found that there was a shift in subtype from subtype B to a more aggressive CRFAE, which is a recombinant form that is more common in Thailand. Was part of it better testing? Maybe 10-15%, but we also saw a lot of people in the hospital with opportunistic infections. In fact, the average CD4 count until now, the median CD4 count at diagnosis is 205. So we're getting them really late. Before it was about 180. So it's improved, but 205 is still pretty bad. You really want to get them 350 or above. And we have the lowest condom use in Asia. So this is the first paper that we worked with. It was self-funded. It was 88 samples. Our TNP are 81 samples, I'm sorry. And we looked at, these were newly diagnosed patients. And what we found was that 75% of them were AE. B was 22%. C was 1%. And there was a CRFAE/K recombinant. If you look at the literature before that, from 1985 to 2000, out of 100 samples, 71% were B, and AE was 20%. What does this look like now that we've gone through the pandemic? It's kind of like when Omicron replaced everything, right? Or Delta replaced everything. So we were thinking that at that time. It wasn't really well known, but COVID kind of supercharged that idea that genotypes do matter. But this was before COVID. And there was a major genotype shift. And the baseline demographics, 29 years old, median time to acquisition was 2.4 years. And the CD4 count was fairly low. And when we compared the B subtypes with the AE subtypes in terms of their CD4 counts, we didn't have viral loads. Remember, this was self-funded. But we had a CD4 machine from the concert. And so we found that even correcting for time to acquisition, estimated time to acquisition, the CD4 count was really lower with the AEs. And, we were thinking, this is emerging, this actually is happening in Indonesia. There are AE subtypes, and this was before we had dolutegravir. And we were thinking about, or INSTIs in general, we were thinking that some of these might become more resistant, so we really wanted to find out. And we did have data that showed this as well, which is the next one. So this was when we finally got some money to do some studies. And this was in 3 of the largest treatment hubs in the Philippines, 2 in Manila and 1 in Cebu. And the money we had for at that time that they gave us was to look at treatment failures in patients who had been in clinic for 1 year. Imagine the Philippine government did not have that data. We had to generate it from a grant. That should be basic surveillance data, but there are different priorities in the Department of Health. So we went ahead and did it. We said, yes, okay, fine, give us some money. We'll take a look at this. And so this is actually not a great sample if you think about it, because these are people who actually stayed in clinic for 1 year. So you don't know how many dropouts there were. So these are the best case scenarios. And what we found was, among the treatment failures, because you can't genotype people who are virally suppressed, among the treatment failures, 84% were AE, 13% would B. And the failure rate was 10.3%. Not too bad, except that half of those actually were pretty, had pretty good adherence to their medications. And what does that mean? There's probable transmitted drug resistance. And that was actually the next grant that we went to. But the other problem is we used to not do viral loads at all. You know, maybe you'll get one at the end of 1 year. And when we did viral loads here, you know, of course, there was a lot of resistance already, because if they failed in the first 3 months, you're on suboptimal regimen for a really long time. Really not an ideal situation. And because we only had limited drugs, the available second line was not great. And this was what we had at that time. We had nevirapine-based regimens. We still had AZT. We had tenofovir. The worst regimen was tenofovir, 3-TC, and nevirapine combination, which literature had actually said is probably a bad idea. It's really a bad idea to begin with. And we saw that. But the most durable, which was unusual, was zidovudine with efavirenz, whereas our first line failed about 12.6% of the time. And so our concern was, you know, at that time, WHO was saying efavirenz-based regimens, this might not be an appropriate regimen, at least for our epidemic, because there were high treatment failure rates for tenofovir, which is not really seen in subtype B. And K65R was really about 7 times higher than expected. That's the signature mutation for tenofovir. And at that time, when we hadn't switched yet over to dolutegravir, we were saying, you know, efavirenz is probably not the best drug for us here. And that actually pushed the government to look at getting other regimens because of such high rates. And so this is when we started to do near whole genome sequencing of HIV because we wanted to look at the subtypes. Remember, the first study was just in treatment failures, so we only sequenced the ones who failed treatment. This one were actually treatment-naive patients, and it was a first of its kind where we did whole genome sequence at baseline, took out the ones with resistance and followed them for 6 years just to see what happens. And so we were able to get 298. Sanger-based sequencing was 77.2% subtype AE, and then 13.8% subtype B. Pretty much confirmed what we had talked about before. The rest had other subtypes and recombinants. There was transmitted drug resistance, about 11%. And CRF-AE compared to B had a higher likelihood of having a high viral load greater than 100,000 and having a baseline CD4 count of less than 50 cells. So there's really a genotype difference based on that data. And so our transmitted drug resistance, where there was at least one drug-resistant mutation present, was 11.7%. I'm not going to show the NGS data here because we don't have time, but it was actually double that. NGS is more sensitive for mutations, and it was actually about 21%. And this was for efavirenz mostly. And it had a higher baseline viral load, lower CD4 counts, and we think that there is a survival advantage to AE. That's why it's replaced B, and that's what was really driving the epidemic. And so we started to recommend doing drug resistance testing if you're using efavirenz, but instead of wanting to do that, actually, then dolutegravir and the INSTI regimens came, and so that's not as important anymore. But that data was important in getting the government to adopt INSTI regimens because our efavirenz resistance rates were going up. And so, like I told you, there was, you know, having all this science is important, but you got to communicate it to the bigger world. And so I actually have a TED Talk. I'm going to have you write it. I'm going to have you watch it as a TED Fellow. So here's the talk. About 4 minutes. The Philippines, an idyllic country with some of the clearest water and bluest skies on the planet. It is also the epicenter of one of the fastest growing HIV epidemics in the world. On the surface, it seems as if we are just a late bloomer. However, the reasons for our current epidemic are much more complicated and may foreshadow a global resurgence of HIV. While overall new cases of HIV continue to drop in the world, this trend may be short-lived when the next wave of more aggressive and resistant viruses arrive. HIV has the potential to transform itself into a new and different virus every time it infects a cell. Despite the remarkable progress we've made in reversing the epidemic, the truth is that we are just a few viral mutations away from disaster. To appreciate the profound way in which HIV transforms itself every time it reproduces, let's make a genetic comparison. If we look at the DNA variation among humans of different races from different continents, the actual DNA difference is only 0.1%. If we look at the genetic difference between humans, great apes, and rhesus macaques, that number is 7%. In contrast, the genetic difference between HIV subtypes from different patients may be as much as 35%. Within a person infected with HIV, the genetic difference between an infecting mother virus and subsequent daughter viruses has been shown to be as much as 5%. This is the equivalent of a gorilla giving birth to a chimpanzee, then to an orangutan, then to a baboon, then to any random great ape within its lifetime. There are nearly 100 subtypes of HIV, with new subtypes being discovered regularly. HIV in the developed world is almost all of one subtype, subtype B. Mostly everything we know and do to treat HIV is based on studies on subtype B, even though it only accounts for 12% of the total number of cases of HIV in the world. But because of the profound genetic difference among different subtypes, some subtypes are more likely to become drug resistant or progress to AIDS faster. We discovered that the explosion of HIV cases in the Philippines is due to a shift from the Western subtype B to a more aggressive Southeast Asian subtype AE. We are seeing younger and sicker patients with high rates of drug resistance. Initial encroachment of this subtype is already occurring in developed countries, including Australia, Canada, and the United States. We may soon see a similar explosion of cases in these countries. And while we think that HIV is done and that the tide has turned for it, just like with real tides, it can come right back. In the early 1960s, malaria was on the ropes. As the number of cases dropped, people and governments stopped paying attention. The result was a deadly resurgence of drug-resistant malaria. We need to think of HIV not as a single virus that we think we've figured out, but as a collection of rapidly evolving and highly unique viruses, each of which can set off the next deadly epidemic. We are incorporating more powerful and new tools to help us detect the next deadly HIV strain. And this needs to go hand in hand with urgent research on the behavior and proper treatment of non-B subtypes. We need to convince our governments and our funding agencies that HIV is not yet done. Over 35 million people have died of HIV. We are on the verge of an AIDS-free generation. We need to pay attention. We need to remain vigilant and follow through. Otherwise, millions more will die. Thank you. Okay, that's my TED Talk. Always wanted to say that. And that was back in 2017 when we still didn't have the insties, and we were really scared that NNRTIs were just going to fall by the wayside. And so this is the National Care Cascade in the Philippines. In the United States, the CDC recommends HIV testing for everyone between 16 and 65 years old because there are 10% undetected HIV among the population. In the Philippines, that's 40%. So we haven't found nearly half of our cases. And linking them to care is also a problem. And testing them, viral load remains a problem in terms of testing. although we're seeing good rates of suppression, actually. The bigger problem is follow-up, which I'll show you in a little bit. We have bad testing, especially for the key populations, and we really have to step up with this because the stigma is tremendous. So that cohort that we followed over 6 years, I told you we excluded the patients who had drug resistance mutations at baseline. So we followed them over 6 years, and we looked at how many of them actually developed drug resistance mutations. And this was before dolutegravir. This was just on efavirenz. And what we found was actually at 12 months, 95.5% of them were suppressed. At 60 months, at 5 years, 89.9% of them were suppressed. These are the people who followed up. But the problem was we lost 1/3 of our patients in the first year. So even more urgent than drug resistance is retaining people in care, because there's a lot of stigma. There's a lot of depression among newly diagnosed HIV people with HIV, and so it's a real challenge. We've figured part of the science out, but now we also have to figure out the behavioral part of it. And so this is really something that we need to address proactively. So just putting all this together, we knew treatment failure at 1 year was 10.3%, transmitted drug resistance was 11.7%, and the more sensitive next generation sequencing showed 21.8% resistance at baseline. And again, this was before we had dolutegravir widely available. We were really scared at that point, and so we said we have to figure out how to detect these patients as well. On top of that, it's not a very inclusive environment in the Philippines. There's still a lot of stigma. There's criminalization of sex work. Needle exchange programs are considered illegal. So some of the people with the needles, they were actually being arrested and shot at. So after that, they just put a stop on it. We couldn't fund any of the needle exchange programs. So after all this, actually, the Secretary of Health asked me to help him what else can we do to try to stem the tide. The treatment hubs have been very successful. We've gotten our dolutegravir, and the viral suppression rates are really very good at this point. But we need to do something because the cases continue to increase. And like I said, I do write a column, so it's nice to be able to get out the thing. Manila Bulletin is the largest newspaper in the Philippines. It has 5 million subscribers every day. And so it's a lot of people. And of course, I think some of you have heard of lenacapavir, which is a drug that you can inject every 26 weeks. And it prevents 100% of HIV cases in women over 3 years in the trials in Africa, and 96% of cases in men who have sex with men. Only problem is about $25,000 an injection. Except that we actually talked to Gilead, and they said that they were going to make us a priority, and chances are it's going to be below $100 per shot. So that's something that that we're actively trying to do to see if we can get our epidemic under control. And finally, after all that resistance data, I figured, we have to bridge the technology gap. There are only 2 labs in the Philippines that do HIV drug resistance testing, the Research Institute for Tropical Medicine and my laboratory. Before that, it was just Research Institute for Tropical Medicine, and it took months to get the results back. By then, your patient CD4 count is really low already, and you're developing even more resistance. So I complained about it, and my institute director at that time said, you keep complaining, why don't you do it? And so I ended up doing it. And so now most of the stuff gets sent to us. But even then, it's a full lab. You need your PCR, you need your sequencers and everything. And so we said, how can we bridge this gap? So one of the TED fellows that was in my batch, she was actually using a nifty little machine called the MinION, which is a portable sequencing machine. And she was giving it to farmers to detect viruses in their crops. And I literally field testing. And I said, how hard can it be? If a farmer can do it, we should be able to set something up. And that's what we built. And we actually developed a test that is basically costs half what regular sequencing has. You just need a PCR machine. And before the pandemic, I was thinking, where are we going to get a PCR machine so that we can do the sequencing? And then after the pandemic, everybody and their mother has a PCR in their lab, right? So that was kind of convenient in that sense, because it's a single-step PCR reaction, and then you just load it into the flow cell, and it tells you if the patient is resistant in about 3 to 6 hours, and at half the cost. And the thing is, drug-resistant testing before was just the PR and the RT gene. Doesn't include dolutegravir and the other INSTIs. This includes INSTIs. So it's actually great for doing the surveillance work as well. So this actually won an award at the Infectious Disease Society of America Foundation. We actually also got funding, about $2 million starting January, to do clinical validation on this. We can actually already roll it out for FDA approval, even with just the laboratory validation, but we also want to make it available to other countries. And so if it's clinically validated, especially resource-limited settings, we can actually do some drug resistance testing finally. And that's still important, even though we have dolutegravir, which is a very, very durable drug. Eventually, people will become resistant to it. The second is, because we don't have drug resistance testing in resource-limited settings, we're forced to use 3 drugs, always tenofovir, lamivudine, and dolutegravir. And tenofovir, over a long period of time, we don't have TAF, we have disoproxil, can be toxic to your kidneys, to your bones. But in the United States, as long as you have drug resistance testing and it's not resistant to emtricitabine or lamivudine, you can get away with 2 drugs. So if we have drug resistance testing, we can spare them using that drug. So this is in the works. Hopefully we'll have it ready soon, and we plan to have it available, even patent-free, to other countries so that they can do drug resistance testing as well. So after all this, it comes back to the patient. Wango Galiaga is one of my long-term patients. He was the son of a famous director. He's a writer as well. And, he gave up so many times, stopped taking his meds. We've had to hospitalize him for cryptomeningitis. And at one point I said, you can't die. we gotta push this fight, and I need you. And so we were able to pull him out again. The community contributed money because he was already financially distressed, and he's still alive now. And he's doing the advocacy work. But it's really important that we anchor it back to the patients, even with all this stuff that we've done. And for Christmas, his father, who was a famous director, drew this picture of him when he was a child, and gave it to me, and it said, to Dr. Salvana, thank you for the gift of life. Thank you very much.
So maybe can you pull up 2 chairs in front, and we will take questions for Dr. Salvana and Dr. Cu-Uvin. All right, fantastic. So we've got a good amount of time. I want to thank you both for being on time. I think this may be the first Global Health Grand Rounds that has been perfectly on time. So let's open it up to questions from the audience. And while all of you are thinking about questions, I am going to shamelessly take a moment to plug our next Global Health Grand Rounds, which will be on September 30th, right here at the medical school, called Digitizing Hope, Using AI and Technology to Drive Global Health Equity. It's going to be a little bit different. Instead of having one presentation, we're going to have a panel of 4 different individuals, faculty working in AI and technology in low resource settings, both in the US and internationally. We're actually going to have an introduction to it by Michael Littman, who is our new Associate Provost for Artificial Intelligence at Brown University. And so I highly recommend everybody put it on your calendar for September 30th. Now with that plug done, let's open it up to questions for our 2 speakers.
Thank you very much. I'm Vanilla Barber, one of the neurologists here. I was just wondering, is the major buy-in primarily in the Metro Manila area, or what about in the provinces, for example, or how was their buy-in in terms of HIV care in the provinces?
Right. So, one of the things, because as we get older, we have more students. So, Philippine General Hospital has a very robust fellowship program, and we've been training a lot of fellows. And so, a lot of my own fellows are actually trickling down to the provinces as well. And so, they've actually been great collaborators. One of our biggest black holes is actually down south in Mindanao, especially in the Muslim predominant areas. There's the stigma in Islam for HIV is tremendous. And I actually have patients who come to Manila just to get care from me because if their relatives found out, they would kill them. I mean, seriously. So that's a challenge. But now we actually have two fellows who are from that area, and they already have worked with HIV, with people with HIV, and they're making inroads into that. And so we're giving them the additional training. So we're very hopeful, especially as we train more people. And they still call me sometimes for difficult cases. I'm always open to that kind of thing. But I think that we need to do a lot of work there. And I'm glad that there are people who are on the ground who I can rely on.
So, in terms of the D43s and the A-trip, because we have trained many people, many of them now occupy high positions in the government or in academia. So one of our trainees is now president of the University of Visayas, which is in the south. And the most helpful people for us are the NGOs. The NGOs that are really taking care of men who have sex with men and transgender women. So I traveled to Cebu, I traveled to Davao, and we are helping these NGOs because they are better than us. Doctors are not trained really for community engagement. We have this training of we come to help. We want to heal you. We are not very good in terms of psychologically or sociologically looking at the environment. That's why we need public health people, psychologists, therapists, social scientists, and the NGOs are very, very good at that. They have peer support groups. They open up easily to them where they won't open up easily to us. So we have learned that we are the procurers of money, and then we give it to the NGOs. So there's equity, when you work with low middle income countries. I think equity is one of the most important things. Bilateral respect for each other. It doesn't mean that because you bring in the money, you dictate. You learn what works and what doesn't work from the people you work with. You're equals. You will never succeed if you don't do that. And that is the most important thing that anybody who is going to work in a low middle income country is you're not this big American coming to save the country. You are at the mercy of the country. I was just telling Edsel, every country I go to, I spend more time meeting with the dean, with the district director, with the, in the Rohingya camps, the chief of the Rohingya camps. You can spend 30 minutes waiting for them because they're very busy. And then they'll see you for 5 minutes. They give you their blessing. Then you go to the next office. You drink as much tea or chai as you can. But that is the way things are done. And you have to adapt to the culture of the country you are working in. You have to be humble. You have to really learn. You learn a lot. And also, let me tell you, that you think we are benefiting these countries? To be honest, these countries have benefited the U.S. population. Look at PrEP. Where was the PrEP studies done? Mainly in low and middle income countries. They help us understand that PrEP works. Look at U equals U. Undetectable is untransmissible. It wasn't done here. It was done in low middle income countries because they have high transmission rates. We would have had to enroll 100,000 people because of our lower transmission rates. I mean, even resistance. That was driven a lot, or comorbidities, HIV, TB, HIV, malaria, HIV, and, mental health. All of them exported a lot. In the U.S., we have HIPAA. We have so many legal individual rights. Community testing in Kenya, where we would go to one village, test everybody so there's no blaming. You got tested first. You gave me HIV. If you test the whole family, they all know about their diagnosis at the same time. But we can't do that in the U.S. For example, the FDA just approved self-collected HPV primary testing. We have been doing that in Kenya for almost a decade now. And, all this cumulative, data was used for FDA approval of self-collected HPV testing. So we do not give the world everything that we are, harvesting in our own healthcare. We have to be thankful for low and middle income countries that have given us the science to use in the U.S. So I think we are mistaken when we think that the U.S. or Europe is the leader of all this because they're published in science magazines, they're published in Nature, they're published in New England Journal of Medicine. But cumulatively, I will tell you that in many areas, we are benefiting from the third world.
We've got two questions there. Why don't you go first?
I know that this summer, PEPFAR was on the table for cuts, and I know that there's, while it may have somewhat survived that, there's been withholdings of appropriations, and then the work freezes and all these also cuts to USAID. So I was wondering, how has that affected your research, but also just the broader research of HIV/AIDS?
The Philippines is not a PEPFAR country, okay? But Kenya is a PEPFAR country. We were severely affected. There were no salaries for workers. There were no antiretroviral drugs that were being supplied. This happened for months, and then they revived PEPFAR. But if you really look at PEPFAR, that's $6 billion, and we clawed back $400 million that they were supposed to decrease in PEPFAR. But if you look at the goals of PEPFAR now, it's very different from the original goal of PEPFAR. So I don't know what the future will be, but PEPFAR will be very different from the PEPFAR that we knew, okay? It will still help, but The Trump administration wants it to be more in implementation science rather than supply of drugs and salaries for healthcare workers. And that will be a very big change for the use of that $6 billion. We just burned 2 tons of contraceptives because our government doesn't want to give reproductive health care to low and middle income countries. How can you burn 2 tons of contraceptives that could have helped low middle income countries? I mean, I can't predict what's going to happen with more rules with the NIH and where they will divert all the funds, but 600,000 federal health workers have been terminated from their jobs. So, and I was just with the meeting with the director of the Office of AIDS Research, and there will be a lot of changes, less funding for HIV, less emphasis for everything except implementation science. Even animal work cannot be done now, okay? You have to use explants. I mean, you cannot do animal research now. I mean, I don't know what's happening, but it's things beyond our control except to be advocates for science and never stop doing that. You are the young generation. I am 68. I'm retiring in December. 33 years I've fought this war, and it's up to you, younger generation, to carry the torch and fight for what will be your future.
Actually, 3 years before, in the last 3 years, PEPFAR was starting to make inroads into the Philippines.
Yes.
We actually met with a PEPFAR ambassador, and they were actually giving some assistance to PrEP, but a lot of the treatment is being paid for by the government. But just to show, so I was supposed to go on a study tour in South Africa with the Philippine CDC in January. We had our tickets, we had our visa, we had our hotels. 2 days before, chopped.
They cut funding to all of
Everything,
South
yeah.
Africa.
I'm just glad I wasn't there already. It would have been harder to go home. But yeah, so
there are some
yeah.
countries they targeted where, and then the universities, even Brown was involved in it. We were demanded to pay $50 million just to get, NIH stopped paying Brown since March. And Brown had to borrow $800 million to keep us all going. I mean, thanks to Brown. We finally got back our NIH funding. Harvard's still fighting the $500 million. Columbia paid $250 million. Duke, I don't know how much they paid. University of Pennsylvania paid. To me, it's blackmail and extortion, but that's just my interpretation. I might be picked up by ICE tomorrow. but you are the most affected. I'm retiring, but I will keep on fighting. I will keep on helping. But you are the generation that will be affected most by all of these changes. So fight, advocate, don't ignore it, It's your lives, it's your careers, it's your futures that are going to be affected, not me who, already did as much fight as I could do and nearing retirement.
You were next.
Hi, I was curious, I know you had mentioned a little bit about the call center worker prevalence of HIV transmission and putting our public health, occupational health hats on. A lot of the transnational companies that go to the Philippines to hire call center workers, are there any services for them provided by the companies like they would a US-based employee? And then the second part of the question, so Dr. Cu-Uvin is, as someone who convinced the Philippine president to do a lockdown during COVID-19, what are your particular recommendations for those of us trying to speak with maybe deaf ears in federal government offices about the science?
Well, I'll ask Edsel, to answer the COVID question because he was part of the Presidential Advisory Committee for COVID. So,
Yeah. So for the first question, BPOs, business product outsourcing, these are the call center workers. We did initially identify a lot of cases there, mostly more because there were a lot of MSM, and we know it was an MSM epidemic. And then we started seeing them in office workers and other occupations as well. So I think what it speaks to is actually the call centers probably are more proactive about testing. And that's why the cases went up rather than, because if you test, you actually find them. So from that standpoint, we actually made them partners. So we make it easy for them to do testing. We've piloted some self-testing work with them as well from a community-based, There's a really cool NGO called Love Yourself that set up HIV testing in Manila and other provinces. It's not even a clinic. It's like a pop-up coffee bar. Mm-hmm. So you just go over there, and by the way, you want to get your HIV test and your syphilis test as well. So I really like that part of it. It was set up by a nurse because he thought that that was the best way, and they were really able to do that. They operate at night as well, because a lot of people can't get tested during the day. So they have sundown clinics as well. It's tremendous, and we learn a lot from, as Dr. Cu-Uvin said, we learn a lot from people. Now for the lockdown, just what happened was, so I was one of three people, all three infectious disease doctors. Two of them were my professors, both women. And we advised the government when we found a case where we could not trace any kind of exposure, we said it's probably community-based already. We had 52 cases at that time. And you can imagine how crazy it was to convince the government to lock down 20 million people in Metro Manila for 52 cases. But we looked at the data from China, and at that time in Italy, it was just melting down. They were picking people out of their houses dead. There was just no room in the emergency rooms. And I said, if that can happen to China and Italy, we have like 10% of their healthcare system, and Manila is closely packed. This is just going to kill everyone. And so we were able to convince the government to lock down in 72 hours. It was a big fight because the financial people were going like, are you crazy? And they were right in that sense. But then we just barely made it when we closed down. We were able to keep cases low. And then everyone wore masks. It was easy. The way that we did it was because Asians are very family-centric.
We have no problem with masks.
Yeah.
There was no problem.
No, the way we sold it was, you're going to be okay, but grandma and grandpa are going to die. And so after that, everyone just wore their masks. In fact, my kids, they got so used to wearing masks. Shortly after the pandemic, I brought them to Alaska. They wouldn't take their masks off. And I said, you're not going to get COVID from the bear. But the bottom line was that people followed. And when we got the vaccines out, people got vaccinated. So in the U.S., there were 1.2 million deaths. In the Philippines, 110 million people, 66,000 deaths.
Yeah.
That's it. So, and that's...
It was also very organized. So I come from a province up in the north, which is like you can see Taiwan on a clear day, okay? I'm 300 miles away from Manila. That's where my family lives. You have to understand that the Philippines, multi-generational families live together. We have no assisted living facilities or elderly homes or anything. We keep everybody in the family. Even if you have only 3 rooms and 15 people, we all live together. We help each other. So that is like Central Falls here. Multi-generational families live together. And so it's easy to convince people, like Edsel said, you don't want to infect grandma. If grandma dies, how do you feel about it? And then the other thing that happened is we are the cities or the districts are divided into what we call barangays. So a barangay is consisted of probably 40 homes or 50 homes. during COVID, you have to get a pass to go to the market, and only one person can have that pass to go to the market. But what the government did is every Monday, you bring out a chair in front of your house, they will give you food and produce so that you don't have to go to the market. I mean, we are a poor country, low-income country, but they were able to do that so that people, don't have to expose each other. And I was very impressed because I thought we would go into chaos. I thought we would be the worst place that would be able to contain COVID. But it's local ingenuity, understanding the culture, that we are multi-generational families. We all live together, and we can't afford to infect one another. So they gave us the food. They gave us everything you need. If you don't have it, you write it laundry detergent. You put it on that chair. Tomorrow, somebody will bring laundry detergent to you, which I thought was very ingenious to prevent people from going out.
So, one here.
I just had a question regarding global foundations. What factors really determine whether global foundations choose to invest in countries like the Philippines for HIV treatment or other infectious diseases?
Yeah. So the Global Fund is actually active in the Philippines, and they initially started funding, because it's just a small number of people initially, treatment. But the way the Global Fund works, there's a country coordinating mechanism through the Department of Health. I used to sit on as one of the institutional representatives representing NIH. And the way it worked was there was an agenda in terms of, we needed this much community testing. We need, now there's PrEP, and then there's treatment. And the good thing is actually we did really well with malaria. Our malaria program for Global Fund is a world model, and we've almost completely eliminated it already. Tuberculosis is always a headache. It actually has the most money.
But we have
Yeah.
children immunization is one of the highest.
Yeah, but TB is very prevalent in the Philippines. We make a joke, your differentials are TB, TB, and TB. It's basically, it's happened so many times. But HIV, now they're starting to close down, not just because of funding, but just because of the cycles. The way Global Fund works, it's really more of a temporary startup. It helps you get going, and then their goal is really to pull out. They don't want to stay there because the government has to take it over. And so we're in that phase. And so when PEPFAR funding and even the Global Fund funding was reduced, we were actually able to take on the load.
Yeah. I think sustainability is not dependent on the U.S. I think that countries have to, at some point, transition to sustainability. And that is very important. And I understand the PEPFAR will not go on forever, but at least give the countries the chance, when your cost of medical care is $1 per year, there is really no way you can easily transition to be sustainable. All we're asking is time to transition. We don't want to beg. I mean, even if you're poor, you have dignity, you have decency, you want respect. You are as human as anybody of you sitting here. You think we like to beg? You think we like to humiliate ourselves, to beg and get disrespect and everything? None of us want that. We want dignity like everybody in the world. But we make compromises because we can't do it. But it doesn't mean we lose our dignity and our decency.
So we'll finish up with two last questions. So I'll have you ask your question, and then I have one from our online audience that I want to convey as well.
So you mentioned the importance of leaning away from U.S. and Western funding, as well as building local innovational capacity within the Philippines. I was wondering what's been the process like of creating this local innovation capacity within the Philippines, especially for HIV?
And then I'll just ask the last question as well, and then you guys can take both of them together. This is from Dr. DeRogers online. Have any of your participants or patients living with HIV talked about mental health concerns? And is there any interest in providing services or interventions to improve their mental health and well-being?
So I'll start with that.
We start with that, I'll answer the second one.
So the Philippine government has actually been very proactive at funding research and innovations as well, including my grants were all from the Philippines. I think they've given me, aside from the $2 million that is coming in January, before that I think I've gotten like $3 million to support all those grants as well, even with the there really is a push, even among universities. I run the lab in the university, but we also provide external services. So we do generate income from that. And so every year we have enough money to buy a piece of equipment that we don't ask for from the government anymore, even though we are National Institutes of Health attached to the state university. So I'm buying capillary sequencing. I just signed off on something. The year before that, I had a 16-cartridge Gene Expert. So I think sustainability has to be built in. We're so used to getting money from the outside, but actually universities have a lot of resources that you can kind of leverage to make it sustainable. Like Dr. Cu-Uvin said, also from reliance on external grants, it's really finite, and you should always be prepared, for the sky to fall, literally, because otherwise it's just very chaotic. And I think part of the problem is that so many countries have become dependent on external funding that also unfortunately kind of stifled local innovation, and they got used to maybe some inflated salaries as well, and now they have to work for local rates. And so I think that it is a double-edged sword, and that we do have to be aware of the drawbacks of getting external funding.
As to the issue of mental health, we are not a country that goes to therapists, okay? I've not known anybody, unlike friends in New York who've been in therapy for 30 years, I don't understand therapy, but 2 weeks ago, I read an article at the New York Times that says the happiest people in the world are Filipinos. And that is true. I can tell you that Filipinos, we might not have therapy, we might not have support groups, but we informally have them because it's the way our society has been, centuries. That's how we've lived it. So, every time I go home, I said, okay, let's go for dinner. And there are 30 of us. We don't need reservations. I mean, here, Edsel and I went for dinner. I had to make reservations for 2. The restaurants in the Philippines can accommodate 30 people without reservations. No waiting time and everything. All our restaurants are made for groups, like big groups of friends, big groups of people. We are so used to it. So we might not have the academic support groups or therapy sessions, but we have friendships, we have family, we have communities, we have our barangays, and that, I think, is informal therapy. And I think if you ask a Filipino to go to a psychiatrist, the only reason you go to a psychiatrist is you're crazy. I'm sorry, but that's the reality of it. So psychiatrists don't make much money, except for the elite, the elites, they follow the Western part. But for the most of us, we have therapy every single day without knowing it is therapy.